Imagine this. You're covering a busy surgical ward, and you get a call. It's about a patient, 2 days post-op from something routine. They were fine, but now the observation chart is just, well, it's flashing red, blood pressure's too low, heart rate is climbing, they're confused.
And you calculate the score, and it's critical.
Exactly. And you're thinking, this could be anything. Sepsis, a bleed, it's time critical. But the senior doctor you desperately need. Unavailable.
Yeah, and that moment, that specific situation, it isn't just about your clinical skills, is it? It's about governance. It's about safety.
It's about having a plan you can execute under, immense pressure.
Right. So our mission in this deep dive is to really synthesize that high-frequency, must-know guidance for handling exactly that clinical deterioration and system risk.
We're going to distill the core principle of escalation.
Based on a whole stack of resources all focused on these safety frameworks.
Okay, let's unpack this. The central idea, the one-liner we're going to keep coming back to is this. Recognize risk early, call for the right help now, safeguard the patient, and document what you did and why.
That's our anchor. That philosophy, it's the shortcut to keeping patients safe and, just as importantly, demonstrating your professional accountability.
So let's start with the core mindset. It's all about safety over delay.
To really get this, we have to define escalation properly. It's not just, making a phone call.
Right.
It is the prompt, structured communication of a rising risk to someone who has the competence and the authority to actually intervene.
To do something meaningful.
Exactly. It's what protects the patient when things get uncertain, when acuity is rising, or when the plan you've got just isn't working anymore.
And the sources are so clear on this. The highest professional reward, it always goes to the person who acts promptly for safety.
Always. Immediate structured escalation consistently beats that really tempting but dangerous idea of let's just wait and see.
Why is that so tempting, though? Why do people fall into that trap of delaying or trying to manage it themselves, even when they're trying to be helpful?
Well, because it subtly shifts the priority, doesn't it? It moves away from the patient and onto yourself. You might be afraid of looking silly, or you don't want to cause an inconvenience.
Yeah, that's a real pressure.
But your duty is crystal clear. And we can link this directly to the foundational principles from the General Medical Council. There are 3 anchors here. First, patient safety must be your first concern. That means you act without delay. It's right there in Good Medical Practice 2024.
And second,
you have to work strictly within your competence. If you're a junior doctor, you have to recognize your limitations. Seeking help isn't weakness, it's a sign of excellent professional judgment.
So if your scope is basically starting some oxygen or fluids, that's where your independent action stops.
Precisely. That's when the need for senior oversight begins.
Right.
And that leads to the third crucial principle. You have a responsibility to raise concerns through the proper channels if those immediate risks are not being addressed.
So if you've done step 1, you've acted, and step 2, you've called for help. But that help just doesn't show up.
Or it's inadequate. Your duty then mandates you keep escalating. You go up the chain.
So the logic is clear. Early structured escalation plus immediate safeguarding. That always outscores delay or trying to be a hero.
You stabilize what you can, and you raise the alert for expert help. Simple as that.
But how do you know? In the middle of a chaotic shift, when have you actually crossed that threshold? When do you have to start this formal process?
That's a great question. We need to identify the absolute non-negotiable red flags that demand immediate action.
Not just, oh, I'll think about that.
No. Instant action. The sources give us 4 high-yield triggers. First, new or worsening unstable vitals.
So we're talking about a big drop in blood pressure, hypoxia, a new WS score that's suddenly shot up.
Yes, that's a non-negotiable trigger. Second, time-critical diagnoses.
Things like sepsis, a heart attack, a stroke.
Where time is literally tissue or life. Delay causes irreversible harm. Third, and this is a systems one, is when no senior is aware of a high-risk situation.
Ah, so it's a gap in the system.
A huge gap. If you know the patient is high risk, but the person supervising doesn't, you have to close that gap immediately.
And the last one.
Ambiguous responsibility. Unclear ownership. If you sense a critical task is sort of drifting between teams.
Or 2 people think the other person is handling it.
That confusion is itself a high-risk scenario. It demands immediate clarification. Escalation.
That list is so useful for cutting through the noise. But let's talk about the moment you see one of those flags. You can't just freeze. The sources give us a kind of a 10-second drill for what to do.
You need structured steps. The sources break it down very simply.
What's step 1?
Step 1. Recognize the deterioration or the risk. It sounds obvious, but it's the most vital step. If you miss this, everything else is too late.
This is what stops you from...
Exactly. Step 2. Alert the correct senior or team. Secure that oversight. You have to know who to call. The registrar, critical care outreach, whoever is appropriate.
And step 3.
Safeguard with immediate measures. Intervene within your competence. This is starting the oxygen, putting on monitors, getting fluids going based on protocol. It buys the patient time while help is on the way.
And to help lock all that in, there's a mnemonic, isn't there? The sources use the RAISE structure.
Yes, the RAISE structure is great because it combines the clinical action with the accountability.
So what does it stand for?
It's recognize risk, alert the senior or service, immediate safeguards, or intervene now, then SBAR for communication, and finally, E for evidence in the notes.
It links the bedside decision right back to the governance trail. I like that.
It closes the loop.
So you've acted, you've safeguarded the patient, now you have to communicate. We all know about SBR, but why is it so much more than just a hospital policy? Why is it so vital in these high-stakes calls?
Because it manages cognitive load. For you, when you're stressed, and for the senior you're calling, who might be tired or distracted.
It cuts through the noise.
It guarantees the most important facts, the situation, and your recommendation get across clearly and fast. It just minimizes the risk of something vital getting missed.
And the sources say that SBR only really scores top marks when you include 2 very specific things in that recommendation part.
Yes, a specific request and a time frame.
This is such a huge insight, the time frame. Why is that so important? I mean, what's wrong with saying, please come review the patient now?
Because it's passive. It's a bit dangerous, actually. Saying, please attend within 10 minutes does a few things. First, it explicitly tells them how urgent this is.
It stops them from just adding it to their list.
Right. And second, and this is crucial for your own professional safety, it secures a commitment. If they agree to 10 minutes, you now have a documented, agreed-upon expectation.
So if they don't show up.
Or if the patient gets worse in that time, your next decision to call the consultant is completely justified. You're not just panicking, you're challenging a system failure proactively. The time frame protects the patient, and it protects you.
The sources have some really good model phrases for this, don't they? The language needs to be assertive, but still professional.
Yes, instead of a vague call, use something like, I'm escalating now. Mr. Smith has a new WS score of 9 with a falling BP. I've started oxygen and a fluid bolus. I require you to attend within 15 minutes to agree on a critical care plan.
It's so direct.
It has to be. The recommendation, the R, has to be clear, actionable, and time-bound. No vague messages.
Okay, so we've recognized the risk, intervened, and called using SBR with a time frame. What's the final step, the one that secures that accountability?
Immediate, concise documentation and continuity. This is non-negotiable. You have to document the facts, the advice you received, the plan you agreed, and critically, the thresholds for calling back.
And the sources are really firm on this. Document later when quiet is a trap answer.
A total trap, because if the patient crashes or another doctor takes over, the audit trail is gone. You have to write a note straight away, even just a quick one.
Like patient hypotensive. Escalated to Dr. X at 02.15. Plan. 1 liter fluids. Re-review at 02.3.
Threshold for calling consultant is BP below 90, something like that. That note is the evidence that you acted, you safeguarded, and you closed the governance loop.
Right. Let's talk about avoiding the traps, because the exam scenarios are just littered with these low-scoring decoys, aren't they?
They absolutely are.
Let's break down the 4 big ones. First, the most common. Observe a bit longer first. Why is this almost always the worst thing to do?
It's just avoidable delay. If there are objective red flags, the unstable vitals we talked about, you cannot wait. Delay in those situations is negligence. You're leaving the risk completely unchecked.
The patient is already on a downward slope and you're just watching.
You're wasting precious minutes. The second trap, ask a peer instead of a senior.
The comfort trap.
Exactly. It feels easier to talk to a colleague, but they don't have the competence or authority for a high-risk situation. Your duty is to get the decision maker involved. A peer can't take on that responsibility.
Makes sense. What's trap number 3?
Send an asynchronous message and wait. A text, a WhatsApp.
Oh, that's a big one now.
It's fundamentally unsafe for an acute problem. You can't confirm they've read it, the urgency gets lost, and the risk just continues while you're passively waiting for a reply. For high acuity risks, it has to be live communication, a phone call, a bleep.
And the 4th trap. This one sounds frustrating. Stop after one unanswered bleep.
This is about an unchallenged barrier. The registrar doesn't answer, so you just stop. No, the risk is still there.
So what do?
You bleep, you wait a few minutes, you bleep again. Still no answer. You immediately move up the chain of command. Call the on-call consultant, the site manager, the outreach team. Document your attempts, but never, ever just give up.
Which brings us to that exact point.
Yeah.
What if your usual senior is unavailable? Or they're just not responding?
You have to escalate to the next available route. In the UK, that's often straight to the consultant on call, the hospital site team, or the outreach ICU team. The key is to document the attempts you made with the first person, and then state the urgency to the new contact. Don't wait passively.
You have to be the patient's advocate.
You are, and this is maybe the trickiest one. What if you get through, but the senior is dismissive? They say, oh, just give some paracetamol and check in 2 hours, but you really think the patient is crashing.
That's a tough spot.
It is, but patient safety is your first concern. Always. You have to respectfully state your case based on the objective evidence, the NEWS score, the hypotension, and then escalate above that person.
And document it.
Absolutely. Document that they were dismissive, document the advice they gave, and document that you escalated further. That shows decisive, professional, GMC-aligned decision-making.
One last question here. What if you're just not sure what's wrong? You just have a bad feeling. The patient looks bad, the vitals are off, but you don't have a neat diagnosis.
The rule is clear. You escalate based on risk and objective observations, not on diagnostic certainty.
You just share the facts.
Share the facts, the vital signs, the score, how the patient looks, and state your genuine concern. Getting expert eyes on that patient based on objective risk is always, always better than waiting until you have a perfect differential diagnosis.
So if we go back to our first scenario, the patient with sepsis criteria, hypotensive, registrar not answering, the top scoring action is a combination of things.
Yes, it's 3 things at once. Immediate intervention starting fluids, oxygen. Urgent, live escalation, calling the next person up the chain using SBAR, and demanding a review within a set time frame.
That's the complete high-scoring answer.
This has been such a clear breakdown. Let's just quickly review the 3 key takeaways you should be carrying forward from this.
First, escalate early when objective risk rises. Never wait for certainty. Never observe passively when those red flags are there.
Second, use SBAR, but with a clear, time-bound ask in the recommendation. You need to communicate the urgency and secure that commitment. And third, stabilize now, escalate barriers decisively up the chain, and document everything. Contacts, advice, next steps immediately. Maintain that perfect governance trail.
You know, if we connect this to the bigger picture, it feels like clinical escalation is as much about professional governance as it is about clinical safety.
I think that's exactly right.
Which raises an interesting question for you to think about. If the highest scoring action requires you to stabilize the patient and document everything at the same time, how do those simultaneous demands, the urgent action and the perfect accountability, how do they influence the stress and the cognitive load for practitioners in a real crisis?
That is a great provocative thought to mull over.
We really hope this deep dive helps you move forward with clarity and with confidence when patient safety is on the line.